Closure AF is being interpreted as a negative trial for LAA closure. I think that interpretation is wrong. I am Horst Sievert from the Cardiovascular Center Frankfurt, and I'd like to share my interpretation of the data. Key findings in one sentence: no reduction in stroke, no reduction in bleeding, outcome driven by early procedural risk. This is the first clinical trial suggesting worse outcome of LAA closure versus medical therapy, widely seen as a failure of LAA closure, and I think this conclusion is misleading. This is the data, multicenter randomized trial, 912 patients with atrial fibrillation and the high risk of stroke and bleeding, LAA closure versus medical therapy, including DOAC, if eligible, primary endpoint tested for non-inferiority, composite of all stroke, systemic embolism, major bleeding, or cardiovascular unexplained death, assessed in a time to event analysis. The non-inferior margin was a hazard ratio of 1.3. The results: mean age was almost 78 years, 38% of the patients were women, CHA2DS2-VASc score was 5.2, Hasbled score was 3, mean follow-up 3 years. The trial missed its primary endpoint. Events had occurred in 155 patients, that is 16.8 per 100 patient years in the device group, and in 13.3 per 100 years in the control group. And this was a p-value of 0.44 for non-inferiority. Serious adverse events occurred in 82% in the device group and in 77% in the medical therapy group. So conclusions of the authors: left atrial appendage closure was not non-inferior to best medical therapy. You can see the graph showing the primary endpoint, and as you can see, the left atrial appendage closure group did worse than the patient group with best medical therapy. What drove the negative results of Closure AF? Stroke rates identical, bleeding similar, slightly higher after LAA closure, CV death higher after LAA closure, difference not driven by embolic events. Excess events came mainly from early procedural complications and higher cardiovascular unexplained death. We have now 25 years of LAA closure evidence. PROTECT AF, non-inferiority versus warfarin, PREVAIL, improved procedural safety, PRAG 17, non-inferiority versus DOAC, 4-year follow-up, multiple other trials, propensity score match trials, trials with historical control groups, single-arm studies, registries had been consistently positive. Is this the first negative trial? Yes, the first randomized trial suggesting a disadvantage versus contemporary medical therapy. All prior randomized clinical trials had been non-inferior or favorable. Registries with more than 10,000 patients generally suggested similar stroke prevention with lower bleeding rates. Signal was totally unexpected also for the authors and requires explanation. Closure AF population is different compared to all other trials. Mean age was 78 years, that is 5 years older than other trials. CHA2DS2-VASc score was 5.2, much higher than in other trials. Hasbled score was 3, that was comparable, but patients with chronic kidney disease, anemia, and prior bleeding had not been excluded, which was the case in some of the other trials. This was really an extreme high-risk cohort. Procedural risk, pre-procedural complications 5.7% higher than in contemporary randomized trials. Early major bleeding, tamponade events, early hazard dominates. Mechanistic interpretation of this trial: stroke prevention was preserved, stroke rates were comparable to anticoagulation, no inferiority in embolic events. The problem was the procedural risk. The concept of LAA closure is still valid. Effects are time-dependent. Events after LAA closure occur early after implantation. Long-term benefit was not captured yet, at least. Bleeding under anticoagulation accumulates over time. Why different from prior trials? Older patients, higher bleeding risk, real-world frailty, and device evolution. The correct interpretation of this trial: not a failure of LAA closure. Patient selection was probably done according to current practice, but current selection strategy in our practice may not be optimal. Early risk outweighs benefit in this trial. Clinical implications: do not close the LAA in very high risk and very old patients. Select patients with long-term benefit. Reduce procedural risk. Future perspective, next generation devices already have or will have less procedural complications. Watchman flags, Amulet 360, Omega and others. Post-procedural antithrombotic regimes already have become simpler, and this will translate into better results. And there are ongoing trials like the Champion AF, Catalyst and Laos 4 and others. Final message. Closure AF was the first negative signal in 25 years. It does not invalidate prior evidence, but it redefines patient selection. Thank you very much for your attention.